Dr. John. Welcome to the Voyage Clinics podcast. I'm a family physician, and today I have a pharmacist with me, Chris Cox. He is one of the folks over at Smith Rexall, a local compounding pharmacy.
Yep.
And I thought I'd bring on Chris just to kind of educate us a little bit in some of the innovations of compounding pharmacy and what's kind of new and what's kind of out there in a various couple other spaces too. So I'm just going to pepper Chris with a bunch of questions today, and hopefully they'll be pertinent to our audience and everything. And I want you to start just briefly, Chris, with an introduction. Tell us a little bit about yourself, your journey, your bio, and what kind of drew you to pharmacology.
Yeah, sure. Well, thanks for having me on. First off, I love working with like-minded individuals where we can sit and dig and just riff on all kinds of different, just the outside the box thinking. Compounding is definitely unique to me. So the path to pharmacy, I liked healthcare from early on. I liked helping people. I liked the science, and I liked kind of geeking out on the nerd side of it, right? The science, the biology, but I couldn't handle the blood and guts. That was like, I know that was you guys.
Yeah, we love that stuff.
We love that stuff, man. You want somebody coughing in your face. I needed like a 2-foot counter space between me and the public. And so pharmacy was a good play for me. So graduated in 2003 to 2006 was pharmacy school. That was in Las Vegas. And then when I graduated, I didn't know where I wanted to go. I didn't necessarily want to go in a hospital. I did several rotations there, but I wanted to be somewhere that was, I had a feeling that retail, like traditional chain retail, is not my space. Those guys, man, they grind. You talk about a space where you can burn out, that's that space. And they don't get a lot of love. But I found just a local mom and pop store, Smith Rexall, as you mentioned, and where I kind of fell in love with the community. I fell in love with some of the patients that we were loyal to each other. We're going to figure stuff out where they would, right out of the gates, they were doing compounding, but not a lot of it. And I just had this inclination to help people that there was gaps in therapy, and they were pretty frustrated with the run-of-the-mill, just going through the grinder of finding what was wrong with them. And so most of it was hormone replacement, a big chunk of it, but we were doing anything that was like challenging pain. We were doing migraines. We were doing hemorrhoids. We were doing throat sprays, nasal sprays. I mean, but in the beginning, we were just kind of a sweatshop, just figuring stuff out, like just putting on we're going in the pharmacy and we'd go into the compound lab, and we would have a patient that would maybe had some kind of dosing challenge, and we'd figure out how to get the medication at the right strength, at the right dose, and the right route of administration, and started having some success stories. And so we would, and usually when you'd make something, you had to try it on somebody, and we ended up doing a lot of like trial and error on ourselves. I remember one specifically where, just one quick story. There was a practitioner that we were trying to, it was a GP, but they wanted to scope patients. And if you're not doing it a lot, I don't think you're that good at it. And so the patients were having a lot of pain while they were trying to scope, doing an endoscopy or something.
Oh, yeah.
So he wanted me to create a numbing product that was better than what they were using. So we found a product that was incredibly. It was in a base that had a bioadhesive mucosal type base that would just stick. So we would coat that nasal cavity, and then he could scope him, no problem.
Oh, like a nasal laryngoscopy.
Yeah, sorry.
Yeah, so an ENT doc.
Yeah, but it was not an ENT doc. It was a GP.
Okay, yeah.
So he probably ENT didn't probably need as strong of, because they were probably more proficient at it. Maybe, I don't know. But this, we did it. I created a new batch, and it was like so strong that they tried it on a patient, and it was like, the patient was numb from like so numb that they couldn't feel air passing. Like they could see their chest rising, but they couldn't sense the feeling of air moving, and they were too numb, and it caused a panic attack. And then in the office, and then she wanted all this imaging done because she thought it was in her brain. And so they were like, it went on for on. And he's like, Chris, something's wrong. You gotta come over. And so I came over. I was like, I'll just try it on myself. Try it on me. That's fine. I'm not even worried about it. I know. Give it to me. So he did the same thing. And I knew exactly what that lady was talking about. I could not feel air moving. I couldn't swallow. It felt, and ultimately it was fine. But it was in the wild west of compounding. You do a lot of trial and error to figure out, and our patients are, my staff and the pharmacists, we try it on ourselves.
Yeah. I think that's neat that you're willing to share some of those vulnerable spaces. I mean,
it was rough.
That there are failures and so there are some struggles and some trials in those spaces. How you in your journey, I think you mentioned something very, very interesting, which was, the big box shops, the big pharmacies, the big CVSs and the Walgreens and the big dogs. Like, I don't know, there's a corporatization of healthcare in general. And I view it, at least in family medicine, as a net negative on care, because those larger corporations tend to be all about throughput, right? They hire these really expensive CEOs and CFOs. They have an entire accounting department, and they very much corporatize the caring of people. And to me, that compromises the whole essence of healthcare, is the caring part, and so I see it all the time in my shop. And that's really one of the reasons I started my own practice voyage clinics, so that we could maintain a quality that is just a mom and pop shop. My wife and I literally run it, and we have, people we know all of our people and their dogs, and we just take care of them like family. Is it the same in pharmacy, like with the smaller shops? I have some patients who are just so loyal to their mom and pop pharmacies.
Yeah. I mean, it's an extension of your family. You've kind of like the mom and pop store. We tell this to our staff all the time. I mean, really, these people that are coming in are they're patients. They're not numbers. They're people that have unique issues and unique challenges, and we know their names. We see them all the time, and we just develop a relationship with them. And it's not just a, hey, how you doing relationship. It's a journey that they're taking with their healthcare, and we feel we're a piece of this cog that helps them get better, and it requires, unfortunately, you kind of like the problem with this corporate healthcare system, as you were mentioning, is you start losing your touch with your patients. It's really the dollars and this is really what is driving it, and it becomes so unaffordable to many of the patients, and so we're trying to navigate not only this road of what they need, but also how do we make it in a way that's affordable to the patient? I mean, the patients only have so many dollars in their budget to offer, and sometimes not even dollars to spend on their healthcare, and they're spending these gobs of amount on their insurance premiums and getting nothing in return for that. So we try to find not only the right solution, but a solution at the right price that's affordable to them, right? And it's not, and it's very difficult sometimes to navigate that. But that's kind of what we're not driven by money, but we're really it's just a family, and we're just really trying to just make it affordable and effective. And those two, and sometimes right now in healthcare today, they're at odds with each other. So chains. Those guys, I got to give it credit. They are grinding some high volume script counts, and with limited, because the pharmacy, the squeeze is happening. There's becoming, in the retail side, less and less budget money for staff, and so the volume's increasing, but they have less staff to manage that demand, and it's becoming an incredibly stressful job. In fact, pharmacy schools today, you see, and it swings from every 10 years, but we're going into a lull with pharmacists that are there's not a demand. The demand is dropping for pharmacists, and it's going to swing back, I would imagine, but it hasn't yet. But it's not a very inviting job market, because most of the pharmacists end up in retail, and it's not like a great. It's kind of a rough place, honestly.
And the burnout factor is high. Just like family doctors, they're landing in these big corporate conglomerate groups, and they stay there for a couple years, and then they're like, I just want to quit medicine. It's brutal. It's just brutal.
Don't they feel like they take the decision making off of your shoulders, right? You feel like you lose your ability to practice medicine the way you want to practice medicine. It's like, here's an algorithm, just plug and chug.
Yep. And it's just, there's multiple layers of demoralizing and fatiguing factors that are just brutal. Yeah. Administrative burden, all the bureaucratic box checking bullcrap that to interface with insurance. There's a whole bunch of things that are brutal in the corporate medicine model, and I'm sure it's similar in that space of the corporate pharmacy space. Are there? I don't know if you can break this down, but like the finances of pharmacology, like a lot of my colleagues in direct primary care, like dispensing, like a lot of the states allow for it, and they're just doing really like, here's your blood pressure medicine, right? Yeah. And it's like 27 cents for like a 90-day supply of lisinopril. And I don't know, like, is there a space in the cost of medicine? I mean, you mentioned to me, it's the same with us. Our core values are like excellent care that's affordable, available, and affable. Let's smile at people.
I like those A's.
The 3 A's.
And you just like line them up.
But the affordable part is hard because we're dealing with, I mean, I got to pay payroll. I got to keep the lights on. And I'm constantly kind of struggling with that. What's interesting is that you and I, mom and pop shops, are looking at ways to make healthcare, make pharmaceuticals more affordable. Whereas the big shops maybe aren't as much. They're looking at, how do I get the biggest margins? How do I, do those kinds of things? Are there factors at play that maybe the average person doesn't see that are strains on the system of pharmacology?
I mean, certainly the insurance model is the biggest challenge. Certainly is a blessing and a curse for patients. So that 27-cent copay for the blood pressure medication. Pharmacies oftentimes are making literally pennies, and or sometimes they're just losing money. And the people that are making money are the pharmacies that are trying to pick that up in volume based medication. So they're just trying to. They're filling just large quantities and volumes on low profits. I mean, it's kind of becoming the new model, right? But you have some people kicking back. So PBMs, that's your biggest challenge.
I'd love to talk about PBMs.
Oh my gosh, that's a whole nother podcast.
What is a PBM? What is it?
Pharmacy benefits manager. So those guys control and make the decisions. Really, we talked about those algorithms. We talked about they decide what's paid for, what's not paid for, and at what quantity. And what's crazy is the PBMs also own pharmacies as well, right? So they can control. They have complete control of the monopoly of the pharmacy side from A to Z, and you guys play by because you'll try to prescribe something, and then the pharmacy, their insurance plans won't cover it because the PBMs are like, no, we're not going to, we haven't negotiated the right price on that, or they just will flat out refuse to pay for it. So
is that why that happens? Because like my patient may have an insurance, it won't change. Yeah. But the medicines change the next year. They're like, oh, we don't cover that anymore. Right. So I have to go through a whole bunch more hoop jumping in order to get that medicine covered,
you gotta
switch it to something else.
Right. They create all these algorithms that you have to follow.
It's the PBMs that
the PBMs are creating all these, and
are they taking money and not providing value?
100%. I mean, they're collecting all these premiums and then just finding ways not to provide. I mean, certainly, I'm not trying. They got people that are very smart. I mean, these guys. These are multi-billion-dollar companies, right? So they're figuring out algorithms to junt people to the cheapest products or treatments or pharmaceuticals. But so that might work for 40% of the patients, right? But then maybe even 50, maybe 60%, but there's still a giant swath of the population that does not work for. And then unfortunately, you're kind of pigeonholed there. And so patients either become stagnant in their health. There's some more creative, there's the science and then there's the art, right? So if just for us, we have to combine those two to create some innovative processes that allow it to be affordable and available to patients. But yeah, PBMs is a huge issue. But honestly, I wish we could go to a place like compounding, for the most part, lives outside of PBMs.
Okay. I was going to ask that.
Yeah. So the PBMs and insurance companies, they don't, early in the 2000s, they paid, like 2007 was probably the tail end where insurances were paying for it. Now there was a compounding. There's pain cream days. Was a time when we were making TRICARE, which is an insurance that the government created and pays for their the military.
Yeah, military. Yeah.
Right. So there was some abuse happening there with compounding pharmacies that were just charging exorbitant amounts of money, and they were paying on those claims. So this is where kind of compounding took a. They were not widely known, and it was mostly covered by insurances. But after that TRICARE incident with the pain creams, they got a bad taste in their mouth and with compounds, and compounds all of a sudden started to become rejected by insurances, and then Medicare rejected them. TRICARE. So once TRICARE rejected them, Medicare rejected them, Medicaid rejected them, and then after that, all the rest of the insurances followed. And then from 2007 on until like late 2017, 2018, so like a 10, 15-year gap, nothing was covered.
A few bad apples.
A few bad apples ruined it for the rest of us. And now, but actually, maybe there's a silver lining, is it allowed us to operate outside of it.
Yeah, I was going to say there's some upside to that.
There's some upside to that. So it allowed us to kind of create our own. It freed us from the kind of the chains of the PBM, so that we could kind of create. Now that the affordability has always been a challenge, but now that what it did is drug wholesale prices for ingredients were incredibly expensive when they were covered by insurances. Well, when those companies, when we stopped selling all that product and ordering that product, prices started dropping.
Yeah, totally.
So it kind of like, it was like this little sphere, little pocket that was free, a bubble from PBMs. And you kind of, you saw it kind of, everything kind of creep down to like normal affordable prices. So the manufacturers of those raw ingredients had to be competitive. Yeah. And then the wholesalers had to be competitive, which made us create an opportunity to, back to your 3As.
Yeah.
It had to be affordable, and it became available. There's still the pain cream ingredients. Some of them are still a little expensive. Like we make a ketamine powder cream that's and ketamine's a little expensive still, but for the most part, all the ingredients just started coming down. So I think it's a small percentage, like compared to all of the volume. Compounded medications are like 1% to 5%. Like it's a low amount compared to the rest of the total volume. Yeah, and it's probably because I would say ours is compounding is more customized medicine, right? It's based on the individual. It's hard to scale that,
right?
And the other challenge is a lot of it. It's education on the pharmacist for sure, because we're creating these new formulas, but it's also the practitioner. It's a steep learning curve for you guys to try to but it's also liberating, but it's frustrating because I'm like, hey, Dr. Saunders, I have all of these. I have like 20,000 unique formulas. And you're like, that's great, but that's also completely like overwhelming. It's too much, right? Yeah. So you're like, you got to find out like what's your happy medium. What do you want to use? But and every practitioner, which is it's liberating, but also frustrating. Every practitioner has their own style,
right?
And they have their own unique. They want this base, or they want this strength, or they want this ingredient. Take that ingredient out, and we recently started a sterile compounding pharmacy, which allows us to do. So now I've always wanted to have a sterile compounding pharmacy, but it's so we before it's been it's been a year. About the time we've had this sterile pharmacy, but before that we could only do topicals and capsules and oral medications and vaginal routes and sublinguals and like so that we were anything non-sterile, right?
Yeah, nothing injectable.
Nothing injectable. But so we've always wanted to do injectable, but there just wasn't a space for it. Kind of this affordability point.
Right.
In fact, I think maybe there's some concern about compounding that it's not regulated. It is extremely regulated by the FDA and also by the states, right? So the Doppel, we just were inspected last Tuesday.
Department of Professional Licensing.
Yeah, Doppel's, it's the
they
state.
Come in and they check on you, make sure everything's on the up and up.
So and it's a good thing, right?
Yeah,
it's
totally.
but we are. A lot of people get uncomfortable because they say these aren't FDA approved products, and it's nuanced. That's a factual statement, but it's also it's not a correct statement as well. Yes, these medications that we're creating have not gone through normal FDA channels of that takes multi-million dollars to bring a product.
I'll correct that a little bit, even because most of the things that you do provide actually are FDA approved at certain doses. You just modify those to customize them to what the patients
need. But when you do that,
then it's not FDA approved.
So that's why it's not. It's off-label use, right?
Because it's off-label. But we use off-label stuff every single day in medicine.
So where it's factual is it's not an FDA approved
regimen.
Well, dosing. So SIG, all that, right? It's not, but it's just because but we have to always use FDA approved ingredients.
Totally, 100%.
Right.
Yeah.
So
that's my point.
Yeah, exactly. Yeah. So we're a very, very, very regulated facility, but that goes to kind of wrapping up the thought that we're doing. I don't know. I forget where we were even going with this.
Well, no. So one of my things I wanted to mention was Marty McCary. He's the head of the FDA right now.
Yeah.
Marty McCary is a disruptor and an innovator, just like me and all my colleagues in the direct primary care space. He was the keynote speaker at a direct primary care conference 2 years ago. My wife and I attended. Voyage Clinics is a direct primary care model. It's like a membership, and we're largely trying to provide the triple A's to everybody: affordable, available, and affable, really good healthcare to our communities. And that's our mission, right? How do we cut out the middlemen of the healthcare equation and cut out administrators, cut out these people? And Marty McCary gave a keynote speech during our conference. So Marty, he worked, I don't know if he's still faculty at Johns Hopkins, but he was like the head of research there. I think he's a cardiothoracic surgeon. This man is an intellectual powerhouse. He's working at one of the Ivy League schools of the United States, medical schools, and doing tons of research. And I remember him sharing some stories, and he is moving the needle in like healthcare. And in medicine, medicine is very dogmatic. It's like, we only do this. We only do this. We only do this. We only do this. Prove it otherwise, and okay, I guess we can change it to this. But we're not going to change it to that because it's 2 steps away from proving. But Marty has conducted beautiful research and beautiful studies that have moved the medicine needle, and it's monumental if you think about it. Like it's incredible. He broke down in his keynote speech during our DPC conference. He just beautifully broke down the healthcare system and where the nuance of issues are. And PBMs are one of them. There's a whole bunch of them. And he's like, okay, this is broken, this is broken, this is broken, and these are all the broken parts. I remember just listening to his keynote speech and saying, man, if only this guy was in charge. He'd be really awesome. Hopefully. And now he is kind of in charge, right?
Yeah,
he's in there, and he's probably shaking and moving and trying to innovate and trying to. Granted, there's bigger tectonic plates at work that he's trying to push around and shift and move. Yeah. But hopefully, I'm
optimistic.
If there's a person who understands, it is him. Yeah. He gets it, and he's smart, and I think he's perfectly positioned to really bring some really cool change in our healthcare system. I look forward to what he does. I'm just looking forward. He
also has he has some ownership in a compounding pharmacy, or he's familiar with compounding. So I'm really happy with the direction that they're going with a lot of their initiatives. Mm-hmm. The biggest one that they want to go down. The biggest road that everybody asks me about is peptides, right? Everybody's like, oh my gosh, can you please legalize and make some of this? Like some of the big ones that are on the FDA's ban list currently, like BPC 157, TB 500. Everybody wants that, and everybody's getting it, but they have to jump through some really, mind-bending gymnastics to get it right from research facilities.
While we're on the BPC 157, is it safe? I mean, a lot of my clients are going and getting it. Like you said, they're just jumping through other hoops. And there's reputable BPC 157, and then there's FDA banned 157, and then there's like non-reputable stuff. And I mean, how do you know if you're getting good stuff? That's why I lean on you guys, where I'm like, hey guys, I trust your ability to procure good product. Make sure that it's pure. Make sure it's not laced with the lipopolysaccharide stuff or whatever. And that's, it's okay for animals, but not okay for humans. And so a lot of these online stores, I don't know how to vet them, and my patients are taking this stuff, and I'm just like, what?
I mean, that's the challenge, right? Is, I mean, there's two sides to this argument. One is, BPC 157 has been around for now. It's been incredibly hot for the last 5 years, but it's probably, I don't know the inception of how long it's been on. But my point is, there's so many people on it, and that it's interesting that the FDA's stance on it. They don't say why they're concerned. They say they have a concern with a route of administration, and they don't say which route of administration that even is.
That's
it. That's all.
They keep it vague so it bans it completely.
They can bend it. So what happens is the state is the one that is going to enforce the FDA's rule. And so we were making a capsule and we were making a troche because we assumed that the route of the route of administration they were concerned about was injectable, which is the riskier route of administration. But the state doesn't. There's not enough guidance.
Yeah, they can't rule on it.
They can't rule on it, so they just shut it completely off.
Oh, dang it.
Yeah, right. Yeah. So is it safe? On the other side of it. This was, the FDA was created because of a lot of probably circumstances that were like this, where there was patients there was a lot of products being disseminated to the public.
Snake oil stuff.
Yeah, exactly. Snake oil that was killing people, right?
Totally.
It was like antifreeze that they were taking.
Right.
There needs to be, the pendulum has now swung so far to the regulatory side that it's impossible to do anything within that space. Now, so the loophole right now is to get it from a research facility, when you get it, it's hard because everything's just not for human use.
Right. And then do you know if it has,
and you don't know what's in it.
Right? Exactly.
And you, to answer your question, I don't know how to trust, and it's difficult. Yeah. It's difficult. And is it pharmaceutical grade? There's a difference between the grades, research grade, pharmaceutical grade. I don't know, and where you're getting it. Mm-hmm. I had somebody that was, practitioners tell me. I just get feedback from practitioners that are sending their patients because I don't have, I don't know what they're doing, honestly. Right. So I hope that we get that. Hopefully, these next 4 years we'll get some clarity on peptides, and maybe there's. We get some, allow some of these popular, very beneficial peptides that appear to have little to no risk.
Yeah. I want to back up just a little bit about compounding pharmacies in general. Sure. I was open to the world of compounding pharmacies from a dermatologist friend of mine.
Oh, really?
And so I just didn't know they existed. They don't teach in residency. They're just like, here's the Bible of all drugs, and these are the SIGs on all those drugs, and the concentrations on all those drugs, and this is what you can prescribe, and that's the way it works.
Yeah.
But in some cases, that's not it, right? Sometimes there's a combination of different things that you can compound that can bring tremendous relief to somebody with eczema or somebody with acne or somebody like all these things that, ordinarily you'd have to buy 3 or 4 different medicines and the concentrations might not be perfect because this one might have too much of this or too much of that. Yeah, and physiologically, pharmacologically as well, the way that medicine works on this person's skin might be too high and it only comes in this one dose. And so then you can customize something. And I remember first time I learned about like one of these creams, I was like, wait a minute. What?
This is a thing.
You're like blowing my mind right now. Like I can give them a low dose this with a moderate dose this and a high dose that all together, and it's like magic.
Yeah.
And some of these docs have just, like you said, I mean, in the trenches have discovered these really neat protocols that they have worked with someone like you, talked it through, told you about the patient's situation, this and this and that, and then you're like, well, let's do this. You have innovation, they have innovation, they put it together, they create something really cool and remarkable for that patient. And then it's like, well, there's one formulation, right?
Yeah, that's most of the time that's how they get it figured out. They have that, you have that light bulb moment where you're like, wait, I didn't have no idea you could do that. And they're almost like dumbfounded because it's not in their book, right? It's not in your orange book or whatever that you're getting your drug information. But it is a mind blowing experience. And honestly, for pharmacies too, because we had like just a teeny course, like 2 days on compounding, and it was more just a novelty. It's like, oh, this is what we used to do in the early 20s, right? Like, but now it's like a legit. It does have science. It's all based in science, and there's the art of it, and the art is the creative, like actually bringing it from theory to practice. That's where the art comes in, because there's quite a, for an example, a lot of our creams used to have air in it. One of the complaints I'd have from practitioners was when they were administering something that was a metered dose, so maybe it's a hormone, and they wanted to get the exact amount of testosterone. Well, when you mix it up, we do a very thorough job. There's a multi-step process to bring the cream together with the testosterone powder. But when you spin it and you put it back into the cream, there's those little pockets of air that start as it sits over the 30 days or however long it is. Let's just say 30 days. The air pockets begin to form, and then so it'll sputter. Like, and you're like, was that my dose? Was that half a dose? Like, what is that, right? Mm-hmm. And so we ended up having to get. We found a company that would make. It was a centrifuge. And so we could
spin it out.
We could spin the air out. So now
funny.
Every cream that goes through that's metered goes through this centrifuge that pulls all the air out. But again, that's part of like the art.
Nuance.
That's the nuance and the art of it that you have to figure out. And so it's just like this process of figuring and just trial and error and figuring out what works and doesn't work. But
can we go through like some of the specialists that you work with and some, we don't have to go through specific products, but I think at least if people knew that you work with GI specialists all the time, Proctalgia Fugax, you got all these things that
we do a lot.
All kinds of really cool compounds.
I mean, you can start there. I mean, we start with our GI guys. Not only do we make so we got a lot of fissures and hemorrhoid products. I mean, there's not a lot of stuff out there for them, but we make quite a few products. We make so GIs, proctologists. We do a lot of ED medications like Trimix or injectables. We derm, as you mentioned earlier.
Tons of derm.
We do tons of derm because derm is. The derms it's like a cash cow for the pharmaceuticals, because they'll make one ingredient and then brand it, and it's incredibly expensive, and patients are just going to pay so much money for these derm products. And so what we start creating these combinations that they're great ideas, are great products, but if we can start creating and synergistically create something that's better than what's commercially available, you can do some lights out things for any derm conditions, which
acne, rosacea,
all that. So and then we do a ton with ENTs. We'll rather than having the patients take, and these are usually harder cases that you're maybe not seeing GP all the time. So, if somebody has a sinus infection once a year or every other year, you're giving an antibiotic and maybe a steroid if it's a bad one. We will, with these chronic sinusitis patients, we will create a topical, and they usually have had a procedure to have the Roto-Rooter I don't know. There's a probably more technical terminology.
The technical. They rotor your sinuses. Yeah.
So they're open and they have access, but we'll create rather than doing, just bathing their entire body with antibiotics, we can create combinations of like 2 or 3 antibiotics based on lab results, and then throw in a steroid, and then they're just bathing their sinuses is all. They're blowing up their sinuses, and that's it. No systemic
effect.
That's right.
That's cool.
So we do a lot of that.
And the nasal numbing sprays.
We do numbing sprays, pain creams. We still do a ton of pain stuff. A lot of
pediatrics with the topical lidocaine. I use your guys' lidocaine for my office.
We do that. Yes, there's a lot of discomfort, some sticks.
BLTs
We're doing
and stuff.
Unique dosing for peds. We do a lot of vet medication. I mean, a lot of these vet patients, they're limited on what they can give their, and the range of sizes of these animals. We can create small microdosing for, little lizards to, be a big Great Danes, and we're doing different dosing, right? So vets, we're doing that.
That's interesting.
We have flavoring. We have you would be surprised the kind of flavoring we have, like liver flavoring. So,
nice.
So, not that we've ever done this, but somebody's not, their drink sitting out and they just like a little drop of liver flavoring. Totally. And awesome. I'm not saying we did that, but somebody might have.
Amoxicillin, throw some liver flavor in. Just trying to get my son used to it.
No, we do some pretty, but so yeah, vet, hormone replacement is huge.
Yeah.
Obviously.
Let's speak to that briefly. So bioidentical hormone replacement therapy, I think the studies, even Marty McCary mentioned, like the study that was done in the 90s that everybody hung their hat on and said, oh, hormones are bad. It turned out when you normalize the data, there was not a significant increase in the breast cancer cause from that study specifically.
What's surprising about that? The Women's Health Initiative was they weren't even using bioidenticals. They're using Premarin to start.
Premarin and methoxyprogesterone.
Yeah, they're doing terrible, not bioidentical. Yeah, right. So that was the challenge. And you're right. Once you look at the data fully, you can extrapolate some things, but not not what they thought it was. Right. And certainly if a patient has some, they have a BRCA gene, or
totally.
You're gonna not get that's rough for the patient because they're stuck with no hormones and it's either cancer or they don't take hormones. So that's a rough one. Yeah. But even those patients we can be creative with maybe maybe we're doing estriol and not estradiol, right? There's still some medications that we can use, but to answer your question though,
the nuance there in the hormone replacement therapy is vast, and we do it quite often in our clinic. I think there's a reasonable amount of evidence, even some higher risk situations where they're just like, no, my life is so miserable. Yeah. I would prefer this, and I'm willing to assume those risks. Yeah. It's not fair what happens to females, I think, especially like males. You can have an 80-year-old male with reasonably okay testosterone levels, and females just go through this total ovarian failure. All of the hormones are gone. And that helps with bone health, brain health, muscle, and skin, hair, tons of all those things. It touches
all these. And I think if you can do it, the tricky thing about these complicated cases, I remember talking to a doctor who told me, because this was back it wasn't like 2008, 2009. So it wasn't but it was like 2011. So we weren't that far removed from the Women's Health Initiative. And people were like, well, where's the studies for the benefit and the risks? I mean, he's like, well, let's just go to your high school biology, human biology, estrogen and testosterone. We know what they do. This isn't. We're not putting something in your body that your body's not used to.
Right.
And we tell patients all this time. You look at the exact molecule. If you were to draw your blood and pull out testosterone, and then the testosterone we're using, and look at them under a microscope, they're identical. That's what the definition of bioidentical is. It's there is no difference between the two. So if you can stay within reasonable dosing, I think where we get in trouble is when we overdose, and females will feel so good on testosterone. But sometimes we push the dose a teeny bit too much, and then they get used to it. And then when you try it, and you probably get some of these patients when they've been on some big doses, and then you try to back them off, they're almost like they're almost at hormone deficit.
Yeah.
But
and when you say we, you mean that folks out there
Yeah.
that push the envelope there. You and I are not doing that.
No.
But I know what you meant. I just want to clarify for our audience. You're not prescribing that. You're not doing that. It's other folks that sometimes do that, and then we left with some of the repercussions there.
There's a place for like doing hormone replacement within you're using symptoms and you're validating with labs. There's it's a solid science-based
very solid
medicine.
So the AUA actually put out a really great article, the American Urology Association, like 50 pages on why it's okay, like in males.
Just wild.
And that's it's actually quite wonderful.
Yeah,
nobody's willing to do that in the female hormone reductive space. And it's a shame. Like ACOG is still on the fence of they're like American College of Obstetrics and Gynecology. They're still saying, minimal amount of hormones for the minimal amount of time to, for these kinds of things.
Isn't that wild?
They're not looking at the overall health benefit of someone being on it. I remember my wife and I, we've done, she likes to go on cruises because she doesn't have to do anything. And neither do I. It's nice. We went on a cruise one time. We haven't gone on a cruise in a long time, but
it's time again.
It might be time. Once upon a time, we went on a cruise, and we went to one of their dinner things. They have these kind of formal dinner settings, and everybody's sitting at a table. And I remember looking across the room, and their cruises have a lot of old people, and then there's us. And we look across the room, and I'm like, whoa. I'm like, you see that gal right there?
Yeah,
she's like, yeah. I said, she's on hormone replacement therapy. You see that gal right there? Yeah. She's definitely on hormone replacement therapy. These are gals in their 80s that look vibrant. Their hair, their skin, they're glowing. They're moving. Their muscle mass, everything about them said healthy, strong individual.
You can tell.
And the physiologic, like you said, the physiology of the equation is risk to benefit ratio, look at it all day long, just look at it and consider that. Yeah. And I'm not trying to give medical advice here or encourage anybody either direction, but just as my preference, I think you can look at the whole equation and be reasonable and just be reasonable. I think we're indoctrinated in medical school, don't do it. And then we're like, well, who's saying that? ACOG, who else? North American Menopause Society. Well, they're actually changing their tune a little bit. They actually do a whole hormone replacement therapy course now, and so I think there is some change coming down. I think being courageous enough to look at the data, discover what's what, and then make some decisions based on information and based on physiology and based on the risk to benefit ratio. Like I always do shared decision making with my clients. I'm like, hey, here's what it is, here's what it does, here's the risks and benefits, and what would you like to do? And folks get to make a choice in my office, and I think that's kind of nice.
And sometimes it's figuring out which is the best. Not only, you talked about this, but it's really the three of us, right? It's you, the patient, and the pharmacist, and we're creating. Ultimately, we're looking out for that patient's health, but can we figure out a way to create really it's a designer medication for this patient that works, and the first route might not be it. We might have to meet tweaks. That's the beautiful thing about it is you have access to all the knobs, and we can tweak and find something. If that dose is wrong, if that route of administration is wrong, we can find something that will work for a patient. Maybe it's an allergy, right?
Well, let's talk about the GLP-1s because that's a perfect space for this discussion. They come in standardized doses, and they're very expensive on the market. If you're trying to run your insurance, most insurance doesn't cover it. They're starting to change their tune a little bit, but mostly no. Yeah. And so you've got the Ozempics, the Mounjaros, those are brand name semaglutide, tirzepatide guys. And in the compounding space, y'all can make different concentrations, and then we as clinicians can say, well, this is the FDA regulated approved dose, but man, that gives you a lot of side effects. Why don't we just take it down a couple units? Yeah. And we can really fine tune that to where they're not having side effects. They're feeling pretty good with those doses and that regimen. And then same thing with the scaling, we can increase it very slowly because we have more of the knobs in our hands, like you said.
You do, and honestly, you have more control. I mean, it's a give and take. The advantages of the pens is they're convenient, and you can click, and it's a game, right? It's awesome. But the downside of that is you give up your some of the knobs that you can play with to tweak the dosing, right? So
and the expense, that's the biggest player. It's like $900.
Expense is huge, right?
Yeah.
And as a compounding pharmacy, we're mindful that cannot be the driver of all of this for the patient. Is it affordable? Yes. Our prices are less than, without question, right? We know that it's that's part of the brokenness of the Marty was talking about. It's broken. So, but yeah, it's definitely affordable. We can also, these patients that one of the side effects is maybe they're dosing too fast, or maybe they're dosed appropriately, but they're still losing not only fat but muscle. But let's put some glycine with it, right? Let's put something in it that'll make it that's been studied and will help improve their muscle mass. Let's put some B12 in it. Patients that, for two reasons, the B12 does help with nausea, so that's one of the other side effects. And the other it's red, so you can see what you're dosing. Which is, you have a lot of these patients that are like Medicare age.
Or just me. 40 presbyopia. Yeah, you can 43 is the average. I'm 47. Like I can't.
I'm doing that. I'm the same way.
In my pocket right now.
I do. But yeah, we can find and more control, and then dosing. You can dial it in. Dial the dose in. I was talking with a patient today. She's like, I can't. 20 units doesn't work for me, but 25 is too much for me. It's like, well, try 21, try 22, totally. Right? Like play around with that dose a little bit. And that's the advantage of compounding, is you have the full spectrum, the full, and sometimes that will lead to an issue. There is the patient that would say like, oh, I was only supposed to take 5 units and I took the whole syringe. Yeah. Okay. Yeah. That's something we have to continually educate patients on, right? Like we got to do this safely. First law of healthcare is do no harm to the patient. So, in our pharmacy, we're not all created equal. We're not all passionate about, whether it's the best price or it's the best for the patient, or it's get the cheapest products that you can find, or it's you have to back to your AAAs. It has to be affordable, and it has to be available. I like the affable one.
The smile.
It's a smile. I think it's great. But you have to you have to go through our journey was at one point. I know we're probably getting short on time, but there was one time I was focused solely on getting us the cheapest price to the patient, and we had a practitioner call me and said, hey, my patient, I have 2 patients that are like, their labs are doing this. I'm not changing their dose, but every time I check them, it's up and then it's down and then it's up. And she's like, the only thing I can think of is it's maybe something you're doing. And I looked at that formulas that they were on, and they were fine. But what I did notice is the manufacturer that I was buying the product from, I was just different manufacturer.
Changed.
Again, I was changing, but I was trying to find, it wasn't for me, wasn't so much quality. I was trying to find out for the cheapest thing. Yeah. And what I found, there's a difference in what I was paying for. I was getting what I was paying for. And my absorption was going up and down and up and down. So at that point, I committed to finding, keeping it affordable, but sometimes it's quality, and what you're paying for is just as important. Sometimes you can be too focused on the affordable side, and you'll lose focus on the maybe access to quality. Yeah. Right. So was
that like a hormone one?
That was a hormone patient. Yeah. That was like, so this is like 2009.
I've seen that. And from one manufacturer to the other, I think they're allowed to have a what percentage of variability?
There's a surprisingly plus or minus 20%. That's
20. Whoa.
That's huge, right? That's huge. Yeah. Now think about your thyroid patients.
And then, but if it's brand name, it can only be plus minus like 2% or something. Like there's
No. In the this is GMP manufacturing is plus or minus 20%.
Wow.
Isn't that huge?
That's huge. That's why I always tell people, if they're on a thyroid medicine, if they're on anything, and the color changes,
that can be
the shape, the size of the pill changes, it can be a significant
when you're dealing
change.
with micrograms, it's a huge deal.
Wow.
So
20%.
So for us though, we put it to plus or minus 5%. We tightened it up, and then we test everything. So all of our products we send out for testing. So we have somebody that new that comes into the pharmacy. They're tested on every single thing. So not only just they get the training, but can we validate that they're proficient and consistent? But then everybody's being tested, weekly. We're sending out labs to be tested.
On the GLP-1s, Dr. Falahati, he's an endocrinologist colleague of mine.
Yeah.
We did a podcast on GLP-1s.
Yeah.
I just mentioned this for our audience in case they're curious about them, how that works and all that stuff. I would go to the Voice Clinics podcast, go to Sugars, Dr. Falahati, Dr. Sanders.
Yeah.
We did a really great podcast on like sugar, American diet, GLP-1s, how they work, why they work, etc.
Pretty awesome.
It's pretty awesome.
Yeah.
It's pretty awesome. Chris, we are running short on time. Yeah. I appreciate you giving us the lowdown, the breakdown on compounding pharmacies. I think it's wonderful work that you do. I love the mom and pop shop vibe of your clinic. We have supported you guys since I moved here from Moab, and really appreciate everything that you do for the community. It's awesome to have like-minded people working for the AAAs in our community, affordability, availability, and affability. It's good stuff, man.
Well, thanks for having me on. It's like sitting down and riffing with a friend, and we're just like having like-minded conversations with help our patients, and let's just continue collaborating, and our patients win, I think.
We're both musicians. That's why we're riffing so well. But for our colleagues who might not know about compounding pharmacies, the docs, the nurse practitioners, the PAs, even the specialists, sometimes their knowledge of compounding options is kind of low. One of the things you did for me to help me is I just wanted my mind opened as to like, hey, what's dermatology doing here? Can I leverage some of what they've been using for years? It's been awesome. I just think all of that space has been really cool. Where can they go for more knowledge on compounding pharmacy formulations? Can they just come to you?
I think that go to our go to our website. It's smithRexallDrug.com, and then you can also just reach out through you can call the pharmacy. Our phone number's on the website. But I would more than happy to sit down with anybody and talk shop. Honestly, that's primarily what I do for my job. Is I go out and just talk with practitioners and just try to evangelize compounding, right? Yeah. And so there's so many success stories, and I know there's practitioners out there that want to learn more. They're hearing about it, and what's driving it is their patients. So if they want to stay ahead of it, go to the website. I have courses that I have access to. I'm more than happy to bring in our commonly requested or most popular compounded products in each of those kind of those silos that you talked about.
That's what you did for me. It was super helpful. Yeah,
that's just please reach out. More than happy to have a conversation with anybody.
Okay, thanks, Chris. Thanks, guys. Yeah. Guys, I hope you learned some cool stuff. Don't forget to like and subscribe, and keep on learning and growing. Thanks.